Control of the hematoma size, bringing down a patient who's got a hypertensive hemorrhage, getting their blood pressure under control. That's really the goal, because if the patient's still sprouting out at 190 or 230 or 380, okay, the chances of those tiny wee vessels rupturing again is still very high. Okay? Seizure management, only if the patient does seize. We don't do prophylaxis seizure management. And assess for other injury. A certain percentage, about 30% of patients who actually present with an ICH have an associated fall. Okay, so just don't assume that just because the patient's in with an ICH and they're tubed that there isn't something else going on. We had a patient who dislocated his shoulder and no one noticed until like 3 days later, and the shoulder was like purple and looking weird. And then somebody said, oh, look at the shoulder, that looks kind of weird. And the patient actually had a dislocated shoulder and another patient had a broken arm. Okay, so just don't ignore the other injuries that could possibly happen simply because the patient is intubated with an ICH. Okay, ICP symptoms occur when they're over 20. Usually they say 22 symptoms start to happen. They're the result of the irritation from the clot, the pressure on the meninges, which gives you the headache, the hemorrhage volume, of course, and the edema surrounding the hemorrhage. The brain doesn't like anything in it, right? So whenever there's anything there, there's a lot of swelling. There's going to be swelling around it. Worsening ICP results from pressure on the vital signs, so knowing that where the hemorrhage is, the thalamic patient is going to be less likely or more likely if they rehemorrhage to push downwards towards the midbrain, so the pupil would go. Patient who has a cerebellar hemorrhage, the thing that's going to go first is probably going to be their pons. They're going to blow, their pupils are going to become pinpoint. They may have Biot's breathing or this agonal kind of breathing. So it really depends upon the location will you tell you if the patient's running into trouble, what they're going to look like. It's a cytotoxic edema, again, of course, because blood is extremely irritable. That's why patients with GI bleeds vomit all the time, because the blood outside of blood vessels is quite toxic. And the hemorrhage can double in size, depending upon what other factors are involved. So always have the head of the bed at the patient at 30 degrees. Also watch patients that come in with a collar. As you know, collars increase your ICP. So if a patient has a collar on, they need to get out that collar once their C-spine is stabilized. So get them out of the collar, keep the bed at 30 degrees. Limit the CNS metabolic demands. Fever, make sure you get your fever down for sure. That's a big problem, fever. Glucose, seizures, analgesic, and sedation. Some places in the United States in particular use 23.4% saline or mannitol, depending upon which one you want, and because it draws fluid out of the central nervous system. It's like Lasix for the brain. Okay, and hyperventilate the patient. So we used to, long time ago, way before many of you were born probably, we used to think hyperventilation was the best thing ever, and we used to hyperventilate patient forever. Right? And then we realized, you know what? That actually dries up your ICP. So now we just hyperventilate patients for less than 2 hours with a PO2 goal of, because 1 millimeter of mercury of PO2 drops your ICP by 2%. Okay, or cerebral blood flow, sorry, by 2%. So it actually can be quite significant in getting the blood flow down, but you don't want to drop it too much because then the patient has no blood flow. Okay? And recognizing that hyperventilation actually lasts about 6 to 24 hours before it all restabilizes in the central nervous system. There's no strict studies that talk about optimal BP. You need to have it really reduce the BP within 4 hours of hemorrhage date or hemorrhage time. That's really the goal by all standards, including the Canadian Stroke Guidelines. You have to frequently monitor it for the first 48 hours. Really, these people almost need to have central lines. And if they're that bad, systolic target is 140. Labetalol is the drug, it remains the drug of choice. Nitroprusside, don't forget, increases your ICP, so try to avoid that one. And lowering it below that actually makes no difference whatsoever. So patients whose BPs come in at 178 or whatever, people aren't that aggressive because studies are showing that there's actually no real difference between a blood pressure of 140 to 180 in an ICH. So, but we lean more towards the 140, getting it down there. That's new evidence that dropping it as fast as you can with labetalol to get the patient down under 140. And long-term BP, if it's an issue, requires individualization, of course. So things you need to think about in the ICU is vital sign dysregulation. Okay, so depending upon the size of the hemorrhage, it's correlated that 30 to 40% of patients with a large ICH or a large subarach will actually have an MI because of the dysregulation. And you will see the weirdest and all the things you could possibly see in terms of arrhythmias or dysrhythmias. They're just wild to watch, and they could be absolutely nothing, and they just kind of go away with time. Okay? Patients will have changes in fever. They'll become hyperthermic or hypothermic. Mostly they become hypothermic. We call it a neurogenic fever. That usually occurs within a couple of hours of the onset of the hemorrhage, really because the brain's hot and angry and it doesn't want to be there. Okay? Watch for, you need to worry about these large volume hemorrhages, the presence of the spot sign, which we talked about. Early presentation to the ER, they actually have found a study that the faster a patient presents to the ER, the worse they are, which is interesting. Those are the patients that have instant ICPs, okay? Whereas if you have a gradual increase in your ICP, you're more likely to say, oh yeah, I've got a headache, and oh, you know, I feel kind of sick right now, and right? But if you have a sudden volume in your head, you have instant ICP, those are the patients that end up to be actually worse off than the patients who wait at home, okay? Because they're more likely to tolerate the hemorrhage as compared to the large hemorrhages, okay? Anticoag use, there's all sorts of stuff out there on if the patient's on a DOAC or if the patient's on warfarin and all these wonderful drugs that we use for antiplatelet or anticoags. Those really need a hematological consult because there's all sorts of things you can use, whether it's fresh frozen or PCC, which is dehydrated fresh frozen, or whether or not you need to use vitamin K and all sorts of things. It really depends upon the agent the patient is on, but the goal is to get the INR less than 1.4. Okay? And then watch for obvious symptoms of ICP. If the patient has a headache lying down and the patient has the same headache lying up, they've got ICP problems because the brain falls into the vault and it actually relieves ICP. But if you sit them down and sit them up, the brain doesn't have anywhere to go, so the headache actually doesn't change. That's why we say raise a patient to 30 degrees because that's the best angle for when the brain slips down a little bit. And when the brain is full, it can't slip down. So that's why if you sit them up and the headache doesn't go away, that means they for sure have an ICP problem. Okay? So when do we consider neurosurgery versus surgery? Because patients' families always want to know, well, I don't understand why we're not taking out the clot. Right? He's got a clot in his head, I don't understand. And you're telling me it's taking up space and it might kill them. Why aren't you taking the clot out? Okay, so we don't take out ones that are small. Ones that are deep, because you can't go in there with a rotor-rooter, right? You can't slice it down the middle and say, well, there you go, it's like 5 centimeters in there, let's just get in there. You just can't do that. Whether or not the patient has a mild or no deficit. If the GCS is less than 4, you know, you sort of get 3 for showing up, so you can't really improve that, right? So if the patients have a GCS of 3, most likely, you know, if they've been 3 for quite some time, so if you have a GCS of 3 for 6 hours, your outcome is 0, okay? You've got 6 hours of a GCS of 3 without any intervention. Chances of return is less than 1%. Okay, so that's why often we say, well, way before your time, before we flew patients in through critical, we used to send patients down before we could see the films and ENITs. We used to send patients down and patients would die in the air or die in the ambulance on the way down. So now when we know patients' GCS is 3, well, how long have they been down? And they say 3 hours. We say, 3 hours. Or the patient has a severe coagulopathy where even if we go to take out the clot, the patient's just going to bleed out on the table. Okay? When do we do it? Well, if it's a large hemorrhage greater than 3 centimeters with an overt deficit, now these are just guidelines. It doesn't mean that it'll happen. It usually happens if it's left-sided, or depending upon age, it can also be age-dependent. So a young woman who's got a large hemorrhage on the left side, this is a horrible word, but they say, is this a salvageable brain? Okay, because if you take the clot out, is the patient going to be so impaired that it's actually not going to improve their quality of life? Okay, with a diagnosed lesion, of course. If they're young and they have a large hemorrhage, brainstem compression is the big one where they often take off the back of the skull. Right, they do a craniectomy and take off a little bit of skull and allow it sort of to mushroom out. Okay, and they remove the clot, mostly because cerebellars can actually do well because they have a tiny weak clot. If you have a clot up here and that's little, Your brain really doesn't care. If you have clot that size in your cerebellum, your brain is not very happy, and it can lead to brainstem injury quite quickly. Okay. So post ICU, after 24 hours, 72 hours, the brain becomes settled. Okay. Though swelling can occur for about a week after, but most of the symptoms most of the damage has been done. Okay. Clot takes about a month to go away. So there's almost no point in imaging a patient. Well, can you do another CAT scan and see how my dad's doing? Well, no, because I'll still see clot. It'll still be there. How the patient is doing is really how the patient is doing, right? Injury as a result of the sudden insult, okay, or the repeated damage and the resulting injury to the neuron if the patient rehemorrhages. There's nothing really we can do to the brain after this initial insult that's going to make the brain injury worse, unless we starve the patient or they're hyperthermic or their glucose is out of control. There's really not a lot we can do at that point in time after 72 hours to worsen the brain injury. So I tell family the injury occurred, what you're seeing occurred at the time of injury. Okay? And patients, at this point in time, after 72 hours, the patient requirements are exactly the same as they are for the ischemic patient. The DVT, the pneumonias, getting them out of bed, where are we going, let's go to rehab. The same things are exactly, the care is the same after 72 hours or so. Sympathetic storm, this is a big deal. So it's worse with the greater the injury. Patients will have these weird wonky fevers that you will not be able to get down. Even though you give them round-the-clock Tylenol, the fevers and we work them up for all sorts of infection, but there's nothing going on. Okay, it's hypothalamic dysregulation. They'll have these weird dysrhythmias, almost to the point that you want to turn off the monitor because you've never seen anything so freaky, because they can be quite profound. And they have a Cushing's ulcer. That's why we put them on. That's why we put them on those ranitidines and Zantac. You always wonder, why do they put these patients on Zantac? They don't have any problems. But when you have these sudden shock to the system, we have liver injury, kidney injury, it shuts down the gut, but the gut still produces the same amount of acid. So it just sits there, and it produces an ulcer, and it's called Cushing's ulcer after Dr. Cushing. Okay? And they go into liver shock. Fever is a common, and it's really related to the inflammation and the hypothalamic hit, we call it. Increases the CNS metabolic rate. So a patient with a traumatic brain injury can actually eat up about 8,000 calories a day. That's a lot of calories. Yeah, a lot of calories. So, and so we have to make sure that we're feeding the patient and they're not getting into these sort of issues about deconditioning as well as just the lack of muscle, but it increases metabolic demand. And fever is within a few hours is considered neurogenic and non-infectious. You can't have a hemorrhage and have it come into the hospital and have a fever within 3 hours and say, oh, I bet the patient has a urinary sepsis or pneumonia. It doesn't kind of make sense. It's really related to the fever related to the clot. And fever requires aggressive management, okay? Because the brain is always 1 degree higher than you are peripherally, and the brain doesn't like to be hot, okay? 25% of patients, because don't forget that seizures start in gray matter, and so 25% of patients who have ICH it will seize. Okay, prophylaxis, we don't recommend it at all because it sedates a patient, and if they're not seizing, why give them medication that's not necessarily warranted at the time. And seizures are considered if there's changes in levels of consciousness without an obvious cause, okay, or out of proportion of the ICH. So we have to worry whether or not the patient's seizing without having overt seizures, subtle seizures. VTE prophylaxis, that's the weird one. Okay, you had a brain hemorrhage, and now we're starting you on DVT prophylaxis. Okay, does anybody know why we use 5,000 units of heparin sub-Q? Maybe know why we picked 5,000? Because 6 sounded too much, and 4 didn't sound like enough. And that's kind of how we picked 5. Doesn't affect your bleeding times, okay? Doesn't affect your bleeding times, right? And so we look at something that actually doesn't really affect your bleeding times, but is preventative, okay? And usually within 72 hours, at the UHN anyway, we start DVT prophylaxis. Sometimes we even start it at 48 hours if the clot's controlled, okay? And don't forget, we do anyway, we order Dopplers if patients have been in the hospital for greater than 24 hours without DVT prophylaxis before we start DVT prophylaxis. Okay? And don't ever use TEDS. Ted's a nice guy, but Ted's kind of useless. Okay, so don't use TADs, they're useless. Studies have shown over and over again, they're uncomfortable. They're like wearing the worst possible control top stocking, and they don't work. They don't prevent DVT. Okay? Short and long term is highly dependent upon the location. Only 20% of patients, when this is significant, returns to previous pre-illness function, which is really quite significant. Okay? The care is similar to the ischemic stroke patient once you get them past the 72 hours. Thalamic pain syndrome. Now, I didn't realize this until I did this talk. There's 4 kinds of thalamic stroke. Okay? And some of them can actually cause a delirium. Some of them can cause a pain syndrome. Some of them can cause motor and sensory loss. And that's why some patients that we see have obvious overt motor and sensory loss of a thalamic stroke. And some patients run into a bit of a delirium who have spared motor and sensory loss. So it really depends upon whereabouts in the thalamus. It's a very sensitive spot. So it can occur, pain syndrome can occur a couple of months or weeks after the stroke, and it doesn't respond to regular pain medication. Okay, and of course the depression patient. So when I looked at this, I found this more fascinating for me just as a clinician and talking to family. So if a patient has an upper extremity weakness and they've had an ICH, function will usually return within 1 month on average. Lower extremity, if there's no movement within 72 hours after the ICH, it's a very poor prognostic chance of return to full ambulation. Aphasia usually lasts functional return by 10 weeks. Dysphagia is rare at 1 year. Sensory loss, permanent sensory loss is actually very common, especially in a thalamic patient, as you know. And visuospatial neglect, 70 to 80% of patients who have a hemi-neglect recover within 3 months. Okay, so this is kind of information. I had to look this up. I have 0 minutes left. Okay, summary. Actually, this is the last one. Acute management for the first 24, 72 hours. So watch your breaks, stare at the patient, be aware of the spot sign. Ask the clinician, does the patient have a spot sign on the CAT scan? And they say, oh, that's an interesting question. And they may say yes or no. Okay? And they say, I don't know, what's a spot sign? Okay? So I don't know what a spot sign. Why are you asking me these questions? Hypertensions, watch for the large volume of the anticoags, and ICP. Okay? And I'm done. Yes.
Quick one.
Yeah.
So when I was in the a lot of our patients that came in with hypertension, I kind of started asking the question because I found medical teams, for whatever reason, some of them would ask the question, do you have a history of obstructive sleep apnea? Because it's been correlated. Do you find a trend in that? Have you in your practice seen that kind of correlation with some of these patients that come in with hypertension?
Well, it is related for sure. That I know. No, I actually didn't. I actually never asked them if they'd sleep apnea, though we found over time it was for sure correlated to it.
Yeah, and I think oftentimes
Yeah.
it's not diagnosed, right? Like,
Yes, absolutely.
They start crying, and the wife will, or husband, for that matter, will say, well, yeah, they snore like a banshee, right? Every
Right.
night, so.
Or they're up 2 or 3 times a night and they never feel rested in the morning, and they have the big tummy. Yeah, yeah, yeah. Or the thick neck or short neck. Yeah, whatever.
I just thought
As we had chips and candy, you know, for lunch break. Yeah, no, they do for sure notice that it's related, for sure. Mm-hmm. Yes,
Sorry, you said when you were talking about interventional, like surgical versus non-surgical.
yeah.
You said, like, for example, a young woman with a left-sided bleed. How come left side?
Because left side, about 95% of the population, they're left side dominant. So speech is there, right-sided motor. A lot of people are right-handed. So the left, you can take out your right temporal lobe and go back to work tomorrow. Your brain wouldn't even miss it, okay? But you can't take out your left temporal lobe or your left frontal lobe. So these are called what we call eloquent areas within the